people are usually coming in for a lack of energy, a lack of libido, just a general lack of good sense of well-being. And again, I say it all the time, as the French say, is joie de vivre, right? I've also found, though, that in certain cases, it can be used intratesticular estrogen, which can affect your libido.
Have you ever wondered if you might be able to cheat death, live longer? Do you want to add, life to your years or years to your life? I'd rather have a healthy, long life and health span and a nice long life as well. But we want to talk about differences in hormones and other topics of anti-aging from an author of the book, Cheating Death. We'll have Dr. Rand McClain on the program, so you don't want to miss it. Hi, I'm back with Dr. Rand McClain and Dr. George Tsiliatos, who are here to help discuss how one might improve longevity, live healthy through hormone optimization and other modalities. So really happy to have you on.
I'm happy to have you here. Thanks for having me on your show.
Yeah, thanks for hosting us, George, at your office. And thanks, George, for coming as well. Let's start with talking about a little bit about your book and the anti-aging aspects of it. And obviously, we don't want to give it away because we want people to read your book. But I mean, basically, you talk a little bit about how to enhance longevity and kind of a broader strategy. If you can sum up maybe the top 3 or 4 items someone should look to?
Yeah, I suppose I could do that. It's been a while since I published the book, so first and foremost, some of them might be outdated, but also I don't remember exactly what I put in there to a T. But if I had to sum it up in terms of the top 3 items, it's probably going to be somewhat disappointing because it's the same stuff probably your great-grandmother told you, which is to get enough rest, okay, to get a sufficient but not too much amount of exercise, to eat properly, right, proper nutrition. Those are really the top 3, which we've known about forever, and there's no secret to those. And unfortunately, actually, there's a lot of, I guess we can even call it misinformation, because everyone's got a diet they claim does it all. And the take home there is, one size does not fit all. Nutrition is very individualized, as is most of what we could refer to as anti-aging or, pursuing health span. Everyone's different, starting from what we talked about earlier.
Yeah.
You and I, your genes, the parents you chose.
Right.
Up to your activities of what we call activities of daily living in the medical world. If you're on an oil rig, working long days of hard labor, the choices you make need to be very different than if you're like me sitting here right now, riding a desk all day for 8 hours. Even if I'm getting 2 hours in the gym or on a bicycle, sitting for that long makes a difference. So without being too long-winded about it, but in terms of, other ways to do it, and part of the reason why I wrote the book is, most importantly, I think my purpose was to sort of let the cats out of the bag, that things have advanced a lot since even the last decade. We're advancing in terms of our knowledge of ways to influence the body toward greater health span, and to let people know, hey, it's not what it was, and I'll give up. I'm just going to go ahead and smoke and drink because it's only going to make a difference of 2 months if I exercise or not. No, we have a lot of other tools available. So you mentioned some other items like maybe considering metformin, things to lower your blood sugar. And it's not just about lowering your blood sugar; it's the way it does it. Rapamycin, the way it activates certain genes which help you sort of reset things, as it were, okay, without getting into too many.
The 6 milligram a week rapamycin dose, is that roughly what?
Yeah, low dose. 6 milligrams is it just so happens to be what I take. As a matter of fact, but it can vary again per the individual. And there's little things like that, and things that people can do. What we call cold therapy now, cryotherapy. Well, I can't afford to go to a cryotherapy machine for $40-$60 a pop. Okay. So how about you stop at the 7-Eleven or your convenience store on the way home, pick up 60 pounds of ice, and throw it in your bathtub, and cryotherapy, man, or spend in this country, $150 on a little home ice maker, and make your own 60 pounds overnight, and then it's even less.
And this cryotherapy is supposed to increase BDNF. Is that one of the benefits of?
We're still studying a lot of these therapies, but so you say, well, then why are you throwing them out there if we don't know? Well, we're studying longevity. That's going to take several iterations, as it were, several lifetimes to really suss it. But we're seeing what happens with the physiology. And I think, for example, with the cold therapy, BDNF might be involved, but I think more to the fore that we've studied is certainly there's a release of noradrenaline. And that's, in many cases, the feel-good part of it when you're done, okay?
You're a little bit of a rush, a bit more Because they can also increase your heart rate a little bit.
Oh, certainly. You jump in, and some that in my office is 150 below. Yeah, got your attention. But also, aside from the noradrenaline, believe it or not, you're releasing something called heat shock proteins. I know it sounds like, what are you talking about? It's cold. Well, we call them heat shock. It's our invention, but they're very protective on the body too. So there is some study with these things. But again, for the long-term proof as to how they're going to affect you, well, we're going to have to wait and see several lifetimes for that. Which brings up the idea of a different kind of not cryotherapy, but yeah, I'm sure there are many of us, probably the three of us sitting here, if we could be frozen, and my wife would agree to it, and wake up, even just 100 years hence, a lot of this stuff will be more set in stone. We'll have a lot more knowledge, obviously, feedback as to what these theories are or how they pan out.
Hopefully, unless we go the apocalyptic route where then you wake up and there's nothing around or you never wake up. Or that one film where everyone gets quite thick, quite stupid, rather than more intelligent, and everything is. And then if you're just average intelligence, I can't remember the name of the film.
Or worse, it's nothing like we planned, like the movie Sleeper with Woody Allen, where you wake up. He was a health food store owner, and turns out milkshakes, hamburgers, and French fries are actually great for you.
So yeah, who knows? So it will be interesting. Well, either that, or you have to get close to the speed of light, or a black hole to cause time dilation, and that's. Are you thinking like
physics will be around?
Yeah. So what else? What about the area of hormone optimization? I know, obviously this is where our channel focuses on hormone optimization. We just got back from the Mr. Olympia, George. We talked about longevity. We talked about peptides. We talked about maybe the strategy of trying to slow down aging or improve health span. But and maybe one of the tactics are, if you're deficient in certain hormones, that can be a benefit. I know you've really excelled in hormone treatment. I think that's some of the base of what you've done. So you want to talk a little bit about on the TRT side, or HRT, or other hormones. Which hormones do you include for your patients? And what are your thoughts, how it ties in with health span?
We're answering you quite literally. I mean, it's kind of a loaded question in that, but you spelled it out. For my patients, we can replace all the hormones, but my patients typically aren't interested in but one or maybe two, possibly three hormones. And more specifically, testosterone is the one that, like the old Saturday Night Live skit for Shimmer. It's a floor wax. No, it's the dessert topping. It gets your attention because it does so many things. And people are usually coming in for a lack of energy, a lack of libido, just a general lack of, good sense of well-being. And again, I say it all the time, as a friend says, joie de vivre, right? And also the inability to control your body composition like we could in our 20s much more easily, right? And testosterone certainly leverages all that, okay? For a female, modulating estrogen becomes important as she goes, from perimenopause closer into full-fledged menopause, and has, signs and symptoms of estrogen deficiency, including hot flashes, night sweats, eventually even vaginal dryness, typically in the 60s. So estrogen becomes an important hormone to modulate. Along with that, progesterone is necessary for the females because of the uterus. So in short, those are the three that most people come for. But having said that, for example, progesterone can be used in males and females. For a female, not just to counter the effects of estrogen on the uterus, but for activation of the GABA receptors, the things that make you feel relaxed, okay? It's not going to act like alcohol or Valium or something like that, but that's just one example of another use for them. And we were talking earlier about, Pregnenolone as something that helps with cognition, in mood, obviously, in some way, memory, your appreciation of color. Now, most people don't come into my office and say, I'm kind of losing my sense of color in my sight, so it's not one of the sexy hormones. But again, we can use different hormones than the top three, we'll call.
What are your thoughts? Do you think the Pregnenolone converts into Allopregnanolone a bit, or does the dose make a difference? Because there was a new drug that came out in the US. I think it's IV treatment for Allopregnanolone, or?
Well, that's a great question, because first of all, for it to be converted into 5-allopregnanolone and dihydropregnenolone, okay, orally works much better. Okay, and as you mentioned earlier, the dosage, the poisons in the dose always, you got to use a sufficient dose. But yeah, that's where you get the attachment to the GABA receptor.
Okay, well, I guess I use a baby dose, 10 milligrams of Pregnenolone.
Close, I mean, interestingly though, quick fun fact: men and women can use equivalent amounts, up to 400 milligrams. Pardon?
I've been using 50.
Yeah, and you find that helps?
That's good.
I find it calms before, so I use the Pregnenolone before bed and DHEA in the morning. A low dose again, 10 milligrams, yeah.
Because DHEA can tend to give you a little bit more energy, whereas the progesterone, obviously taking orally, should help you relax.
Though DHEA helps also reduce anxiety as well, right?
Well, that sense of well-being, and this is where it gets really complicated, and I argue very fun for us anyway, because you have to mix and match, and you have to adapt to the individual and find out how they react to it. Because, as I use the word a lot with testosterone, for example, with leverage. If you're an anxious person to begin with, right, and there's not much, just for argument's sake, that you could do about it, well, then you're going to give yourself more energy to be anxious. But if you can, because you feel more energetic and less fragile, maybe, like when you're sick, the world sucks, right? And, you react to everything. But, if you're feeling like, oh, I have confidence, I feel better, you're less likely to feel down or anxious because you don't feel like, oh, the world's coming down on me. So you see how it can react differently for different people.
Of course, yeah, everyone reacts differently to testosterone. We've had the stories of the testosterone cream and the patient's up all night and they're full of worry, and other patients, they take it and they're absolutely brilliant on it and they love it and it's changed their whole life. So everyone's so individual, and you've probably seen that too in your practice.
So it makes it fun for us, but maybe not so much fun for that individual patient, right?
Do you measure the Pregnenolone on certain, or do you measure
you mean for
or DHEA for the essays?
Yeah, no, we have we had one instance where an older somewhat small lady was sent home to come back for another draw because they were taking so many bottles of blood. It's a joke, but yeah, I mean, we try and be as comprehensive as possible and reasonable. She's the only one, and I don't know what the lab assistant was really thinking about, because you should be able to give 11 vials of blood or whatever without having an issue. But the point being that all these hormones, back to your earlier question, can be manipulated and do have some value in doing so if you and the patient are willing to do so, right, Jordan? I mean, how many times does someone come in and say, well, I feel great on testosterone, doc, but I'd also like to adjust my Pregnenolone and my DHEA? I mean, it's usually something that we have to introduce because we're treating a sign or symptom rather than the patient's raising their hand, right? At least for me. Yeah. Or for fertility reasons, to preserve or return, fertility or limit its loss. I've also found, though, that in certain cases it can be used, and it's not often, but we were speaking at lunch about intratesticular estrogen, which can affect your libido. So occasionally I'll use it for that too. How about you?
Yeah. Do you believe that HT implementation improves the stereognosis? Since when you inject testosterone, you shut off the testosterone production from progesterone, pregnenolone, progesterone, etc. So when you introduce the HCG, you improve the whole stereognosis, or it's a myth?
Well, good question. We'd have to do the studies, the properly designed studies. Again, we were talking about that at lunch. But it makes sense theoretically that, you would have what we refer to as backfill, right? If you were producing some endogenous testosterone and the body realized, not just because you have extra testosterone exogenously, and again, this might be reaching, but, oh, okay, now I don't have to, for example, convert DHEA into other hormones or even pregnenolone further up the cascade. It remains to be seen, but it does make sense. Now, one thing I'd like to have studied, not to leave the subject necessarily, but we do have LHCG receptors in the brain. And I remember early in my practice noticing that some people did better than others when using HCG. Some people would get, moody. And so maybe there is an effect that we're maybe overlooking with HCG,
again, neurotransmitters of setting.
Again, it remains to be seen. It's a homolog, right? I mean, it's so close in nature, LH and HCG, they call it HCG receptors. That's something I'd like to see studied more, because I do warn patients to say, okay, well, we're working on fertility here, but just be aware that you may notice some mood changes. But on a regular basis, do I say, and in addition to this, we should throw in some HCG? No, I don't do that, because, again, I don't have that study as proof. And two, practically speaking, in this country anyway, it's expensive to add HCG.
Yeah, it is. It made it really difficult.
HMC isn't more expensive, right?
Well, but all those, I mean, ideally, if you can get the actual recombinant LH, recombinant FSH, that would be the, I think, ideal, because that's the actual hormone that a man would produce. Unless they have testicular cancer, then you'd have a high HCG level, wouldn't you? Yeah.
You prefer the use of clomiphene or HEG for the sake of the testicular function?
That's a great question, right? I know you're asking me a leading question, so I'll answer. Well, I always answer long-windedly, but thoroughly, I guess I'll say. So, first of all, I don't like Clomid because it has the two isomers, right? Zuclomiphene and N-clomiphene. And zuclomiphene, we think, will act actually on the estrogen receptors and make you feel crummy.
Agonizing them, yeah.
Yeah, and it has a really long half-life compared to clomiphene. So I choose to use what's been available since 2015 in this country in clomiphene and avoid those side effects. But then again, the choice between that, where you're indirectly activating more testosterone production because the pituitary is saying, "Oh, I don't recognize enough estrogen," and the testosterone's low. I feel free now to send a signal to testicles. Whereas ACG, as you know, just overrides the system and says, "You're going to do what we tell you to." It's the signal itself saying produce something for the.
It has a clomiphene apart from the remote, it gives you blurry vision, and sometimes it raises HBG that tanks the free testosterone. So it's counterproductive. So it may work in the paper, but people don't feel good, even in the sex drive, because it lowers the free testosterone.
Right, and what's the purpose? Is it to get the testosterone levels up or for people to feel good? Exactly.
What about with the N-clomiphene? Do you see those same side effects?
No, I don't. Not at all.
Yeah.
Never.
So
Never once, and I can say that. It's rare you can say never. In clomiphene, it makes sense theoretically. It just doesn't work that way. It doesn't activate the same receptors.
And you've not seen the elevation in SHBG from the N-clomiphene, have you? Or I would assume that would be the proestrogenic effect of the elevation in the SHBG from the traditional clomid compared to the N-clomiphene would be almost anti-estrogenic.
I can't answer that because I typically don't get an assay of SHBG.
Okay, you said it's
doesn't matter what. Yeah. There's more than one way they can, and just practically speaking, for me, doesn't work. But it would make sense, and just I'll make this point because it's overlooked a lot. When you're measuring, like I'll get the complaint about, well, doc, you're asking me to take 3 milligrams of anastrozole now a week, and with one, I went from free testosterone of 60 to 30. So now I'm going to take 2 more tablets. That doesn't make sense. Well, it's not linear for the very reason you just said. Whether we're talking about testosterone or estrogen, SHBG lowers also when you tend to lower the estrogen, certainly, right? And so you're working at it from both angles. Yes, you're lowering estrogen, we'll call it. You're blocking the reception of it, but you're also lowering your SHBG so more becomes available. So it's not linear when you start getting down to the ideal levels.
Years ago, one of the endocrinologists had treated me. I was having really high prolactin levels and really high estradiol levels. And obviously back in years ago, in the late 90s, it was quite a big whammy of an anastrozole that they would use. It did bring down the estradiol. It did bring down the prolactin levels at the time. I know there's lots of controversy around this topic of, and George's like, oh, we don't want to talk about it again. But it's important because we said all tools should be on the table. I think ideally, you wouldn't need to have any of those tools. Ideally, for most patients, you wouldn't need that. So, I mean, I just want to ask you a question about that. There are many different reasons we talked about. And I know I've got some friends in the space that will absolutely say, no AI at all. And I love my friends. I don't want to upset them. But at the same time, it just seems to me that having some tools available in certain circumstances, and even some of those friends that are in the medical community in the US are very much anti-using any of those tools, aromatase inhibitors, will say sometimes on the side, say, well, there are some subset of patients, very few, very rare, that it may benefit those guys. So I don't know, I just want to know what your opinion was.
Basically, pick up from that statement, so we don't beat a dead horse. I realize people don't realize what the conversation we had at lunch, but it's more than just a few. Yeah. If you take just the gynecomastia patients, it's certainly more than a few. And so you have to address that. And unless you're willing to reduce testosterone, therefore reduce the therapeutic effects that the patient came to you for at the beginning, it doesn't make sense. Okay. So you have to incorporate something, whether it's an AI or a SERM, to modulate estrogen. There are other considerations, though, that I think I put in the book, but I'll say out loud again. There are certain estrogens that we know are associated with estrogen-sensitive cancers. 4-hydroxyestrogen, 4-hydroxyestrogen, 16-alpha-hydroxyestrogen. No guesswork there. So we definitely want to modulate some estrogens downward. We're not sure that they're all good or all bad, but we have identified some bad ones in the estrogen family. And in general, it makes sense to lower that family, again, in general,
I think this one last time about DIM.
Right. I wish you can do that because DIM has a side effect. Well, DIM's beautiful in that it has some anti-aromatase action, and it also converts the so-called bad, the ones I just mentioned, 2 of them anyway, to the good, and converts, prevents the conversion from the good to the bad. So that's a great alternative. But if you're producing an excess amount of estrogen for whatever reason, you got a lot of fat mass, your liver just does it because of the parents you chose, whatever the reason is, then that DIM is typically not going to be enough to prevent gynecomastia. So you're going to have to do something, whether it's a SERM or an AI. And the problem I want to get to is it's not the AI that has some innate problem with it. It's the overuse of it. Yes. When you have a patient that has gynecomastia and you have to solve that problem, if you overshoot it and you modulate the estrogen too far downward, then you're going to have issues. Yeah. Ranging from joint pain to just long-term having lowered your HDL, for example. That's one of the possible side effects.
So as well,
it can affect a lot of people's libido who are sensitive to too low an estrogen. There's a lot of effects for bearing your estrogen that can come to the fore. But long term, we know you need estrogen a certain amount for good health. You don't need a whole bunch so you get gynecomastia, though. So we have these camps of which you're referring, where you have these people that are adamant about no AI, which doesn't make any sense. And then you have camps too where you go, oh, you absolutely have to have an AI. Well, no, that's not true. It all depends upon the individual. We were talking at lunch. I use myself an example. I'm not going to talk about any patients, but when I first started in my 30s, was using to control estrogen, estradiol sensitive is used as a surrogate to get that sweet spot of about 20-25 picograms per milliliter, 1 milligram a day of an estradiol. And it wasn't fat. It just happened. But he claimed he wasn't fat. And then nowadays I use 0 because with age, I'm producing less, and I find that's across the board typically, and being on TRT for a long time, you don't need as much. So again, you tailor it to the individual circumstances. But to say it's all good or all or nothing, attitudes are crazy.
What about lower the dose of the testosterone? I mean, if somebody aromatizes, let's say, has an itchiness and symptomatic at 200, why not to go to 150 in order to avoid the use of AI?
That's absolutely an option, right?
Yeah.
As long as you don't, I say as long as you don't reduce the reduction of, sorry to use a double negative there, of symptoms and signs, right? Which is the purpose of using TRT. Some people go, yeah, I'm just as good on 150. But if it happens that reducing your weekly dose of an esterified form of testosterone by 50 milligrams lowers the effectiveness of treatment, then you're faced with the decision then. I won't say it's right or wrong, but then you say, okay, yeah, I can use less AI or none, but am I willing to trade that for the other? That's up to the patient and the doctor.
I mean, where do you think a therapeutic dose, or maybe not just a dose, because the dose is highly individual. Where do you look at the trough? I guess you look at the trough level of testosterone. I think I've heard it was you maybe that said, 800 milligrams and above, or is there a particular number?
I want to say the 50s even.
Or 800 what was it? 800 nanograms per deciliter, yeah.
They weren't even looking to free T back then. So they use that now. Guys, and I mention him all the time because he's one of the leading guys. If you look at the papers in the United States, I mean, Dr. Lipschultz is included in most of those papers, and a lot of his fellows, Ramasamy, I'm going on, but there's plenty of guys out there that use the same protocols that arguably he developed.
He also uses aromatase inhibitor for the fertility protocols because it does something for the testes. I've got my own personal. I'm not promoting them because sometimes if you get it wrong, then you feel really bad joint pains and too low. But I had noticed for many years when I didn't have HCG, and I've been on it for 27 years, the testosterone treatment, that. And it's anecdotal, but after using aromatase inhibitors, and at the time like you, I was on quite a high dose, I didn't get the shrinkage of the testes. In fact, they would feel a bit fuller after a bit of aromatase inhibitor. So again, that's my experience. I don't know if anyone's watching, if they've had that same experience, let us know in the comments. But yeah, in general, that's something I've seen. And it may have kept things, because you hear there's some of the guys, I don't know who these guys are, but they'll say, I've done my testosterone treatment and, my balls go up into my body. And, everyone's built differently. I guess everyone's anatomy is slightly different, but I've never seen that experience myself.
Wow. I'd have to think about why theoretically that might happen. I'd be interested to see how people respond if that happened to them too. I can't think of
the fertility point of view. That's why Lipschultz had put that in the protocol.
Well, I can speak for sure, at least for one rationale, which is the one we mentioned already, gynecomastia. I mean, I was fortunate enough to round with him. which is not easy to do.
You actually know him. I just know from the paper, the name on the paper. You got to run with him.
But he definitely, will is a proponent of using, AIs preferentially. I've seen him use, but something to modulate the estrogen downward when the patient has gynecomastia. I mean, to me, it's just a no-brainer. Why wouldn't you?
What about the other cases? If you have an elevated prolactin level and a high estrogen level, would you feel comfortable offering that, or do you think going directly to fixing the prolactin problem only is the best way? So would you use like a DIM or calcium D-glucarate, or go right to?
I don't mean to dodge the question.
Sorry,
but I
didn't mean that.
No, it's a great question, but I think we're getting into more of the nitty-gritty where I'd have to feel safe in answering that. I'd want to see I would want to see the whole page.
All the page, yeah. It's quite hypothetical. Yeah.
Hear more about the history. How long has this been going on?
Yeah.
If there's high prolactin, just to throw something out there.
Fair enough.
High prolactin because of
because you have just one single test.
Hyperammonoma.
Yeah.
And okay, we're going to deal with it totally differently, possibly.
Right.
Because it might require just a quick and easy surgery.
Yeah.
But a common surgery, and then we don't even have to think about the prolactin anymore. So
No, that's fine. That's fine. Do you see that often in patient groups? Elevations, a transient rise?
Too often, you would think.
Yeah.
I see. Are you talking about prolactin?
Prolactin.
Oh, absolutely. I see it a lot. As a matter of fact, I stopped getting prolactin assays because of it. Why? If you look into the research, people on TRT, at least the dosages I recommend, along with Lipschultz and others, will have slightly elevated prolactin very often. I would say probably, I used to be an accountant before I was a doctor, so I'm presumably honest and conservative, right? So to try and err on the side of conservatives, I'll say 40% of the time. But that was enough to drive me crazy, and the patients too. And doc, do I need cabergoline? I have a prolactin issue. And of course, they confuse the prolactin issue, as it were, with endogenous production versus you're already on TRT. So no, it really doesn't make a difference anyway. But again, if you look at the research, elevated prolactin mildly, so you might see a 16 or 18. Yeah. I've seen it as high as 21, but non-consequential, at least in terms of the patient function and feeling, when on TRT. Interesting.
TRT, yeah. Okay.
But the totally different circumstance, I would say, if it's a patient that is dependent upon his endogenous production.
And were they on other medications like SSRIs or proton pump inhibitors?
State that across the board, including nandrolone. Yeah. By the way, in terms of that, I'd be interested to hear your findings on this, doc. I've had patients come in, not a whole bunch, but I've had bodybuilders that have used nandrolone and are on, a couple of cc's of nandrolone a week, which is much higher than the therapeutic dose, obviously. And, they're complaining about nipple sensitivity and some gynecomastia early stages. And they say, yeah, doc, I need some cabergoline. I said, whoa. Let's look at our bromocriptine. Let's look into this. No, I know it's prolactin. It's got to be the Deca, the nandrolone.
Yeah.
And
are they using testosterone as well?
Yeah, using testosterone as well.
Abusing.
Probably. Because they're using too much nandrolone, they're using too much testosterone these days. That seems to be the way they do it, which that's a whole other topic of why you do that. I don't understand it. But anyway, I've won every single bet. I say, hold on, I will pay for your labs. If when we get them back, you have high prolactin and your estrogen is not high.
Yeah.
I won every single bet, never had to pay for the labs, because it is high estrogen that they didn't figure into the equation because of just what you mentioned. They double or triple the dose of testosterone, and they don't realize that that's what, it's converting to extra.
Testosterone is more estrogenic than Deca, right?
Of course. Yeah, way more.
And I think Deca can also lower your SHBG and maybe give you more beta.
It's not strong. It's not strong androgenic, the nandrolone. It doesn't bind as DHT to the SHBG. Does it?
The
nandrolone, does it lower the SHBG? Does it bind tightly to the SHBG?
Again, SHBG is not my bailiwick because I don't typically get it, so I don't observe that. But I know that, it's purported to be non-aromatizable. But I think some of the studies show that as much as, not frequently, but as much as, whatever that means. So once in a blue moon, it can be 20%. But, mostly I don't see a lot of conversion of nandrolone into estrogen from what I can tell. It's usually they also add the testosterone and forget, that can convert now, all that extra testosterone.
I think, sorry, Maria. Speaking of Nandrolone, Deca-only, I guess the brand name, we had a question from the channel from one of the people that left a comment. They wanted me to ask you about a Deca-only version of TRT.
No way. Actually, it's not TRT. Well, it's a replace for
DRT, right? DRT, exactly, or NRT, right? Well, that's interesting because in my day, remember, I'm going to be 62 soon, guys. For various reasons, not available. We just didn't think this way. We would use the anabolic steroid and would not use testosterone along with it, and got great results. And for women, it happens to be a great choice, as is oxandrolone, because it's very weak as an androgen, converts to dihydronandrolone, not DHT, and so very few side effects. And you don't have the conversion into estrogen except for rarely a little bit. So I've seen women that use a very small dose of nandrolone, particularly like I had a patient
for the bones.
Can help with bones for sure. I mean, all the testosterone, all the androgens. People talk about estrogens. Well, how about testosterone, guys? And of course, you still got to do the weight bearing exercise. But I had a patient that had a post-COVID issue and was losing weight very rapidly. Oxandrolone wasn't going to do it. She had some GI issues, so nandrolone was a great choice.
Doesn't affect the lipids as anabolic, right?
It doesn't as much. That's true. Yeah, I would say. I'm glad you said that, George, because these are things that we observe through through the practice. Because I would agree with you. In my, again, just observations, not a study, it doesn't tend to affect the lipids as much. They all do, right? But I mean, certainly, stanozolol just destroys your HDL. Yeah, oxandrolone not as much, but still. But nandrolone, I don't see it as much at all.
I mean, George tells the story of his 108-year-old grandmother.
Yeah, I mean, with younger, she died 106.
106.
When she was 104, she got pneumonia. She has to be hospitalized. So me and my sister, who's a pediatrician, escaped from the traditional medical rules of the medical board and the hospital. I mean, my brother-in-law, she's married to a cardiologist who has no clue about that. So we're injecting her for 2 years, 100 milligrams of Deca every other week. No bone fracture, no cellulitis, hematocrit 41. And she was able, of course, to do some physical therapy. And she survived for 2 years, yeah. And, of course, with a plethora of other supplements, that was something miraculous to her.
And that makes sense, right?
A little bit of mustache,
No.
Great.
That is a great story, but that's, and I think I did put that in my book, is that, and not that I don't even want to make reference to the book. I just want to make it sound like I'm being repetitive, but anabolics, they got such a stigma attached to them.
We're made for elderly people.
It is absolutely perfect for elderly patients, right? Because that's when you're lacking in muscle. That's when it can be life-saving. I mean, God forbid, pneumonia is bad enough. I mean, typically, right, the typical patient, your grandma's age, would fall, break her hip, be hospitalized and get hospital-acquired pneumonia and die because of that, okay? So why not protect against that kind of fall, that kind of trauma resulting from fall, which if you look at the stats, I want to say it's like the third leading cause of accidents, fall, stuff like that. But that doesn't factor in, because if you don't die from the fall within 3 days, at least in this country, it's not counted as death from the fall. You die a month or 3 months later from hospital-acquired pneumonia, and that doesn't count as an accidental fall. So what I'm saying is the numbers are probably higher. So that's a perfect way. I mean, I'm glad you told that story. That's awesome. It amounts to 50 milligrams a week. That's a hefty dose too for, so you don't use a higher dose for a 104-year-old. I could tell you a quick story if it may. We can always edit this out, right? But when I first started, I had an 83-year-old woman. I had an office in Whittier, and her chief complaint was, lack of energy, wanted to move more. She already, for her age, had plenty compared to most. But, again, it should be compared to yourself, right? But her main thing was she wanted to have energy to garden more. Great. But I was young. It was early in my career. I didn't know as much as certainly I know now, I hope to think. So I started on 15 milligrams per ml of a transdermal each day. 6 weeks or so later, she comes back in when it should have kicked in. And she started, actually it was 90 days, and she complains, I don't notice any difference. And I go, oh, I'm like, okay, because, this is my first failure, so to speak, And I said, well, I started on 15, we can go up in dose and go to 20. She says, what? Why did you start me on 15, not 20? I'm like, well, you're 83. She was pissed, and I understand why, because she's 83. It's not like time is is not of the essence. She doesn't have abundance of it, and she didn't get to the garden. And I learned my lesson early on that you can use, at least what I found, and you can tell me if you found something different. It's not that you're using the same dose for everybody. A standardized starting dose is okay. Just because you're older doesn't mean you can't benefit from it. Okay, now if you had kidney disease, if your grandma had that, then you have to factor that in terms of the metabolism of it. But you can still use a hefty
The
dose.
older you are, the GFR lowers according to the formula because you implement also the age.
Of course. Yeah. So that's a great story to hear that you can use that much. That's a hefty dose of nandrolone, arguably per week, right? Yeah, and it worked.
So you would.
She made it another 4 years, and it wasn't just like 84 to 88. It was 104 to 108.
That's fantastic. Yeah, I guess that's the story of a monotherapy nandrolone story. I think traditionally it's used as an adjunct with TRT when it is used. Though I think in the late 90s or the early noughties, there were some studies or thoughts that because of the potential side effects of the prostate of testosterone. No, I know that nandrolone would be used as a cell therapy to avoid the traditional side effects of testosterone. Just like they had started developing those SERMs, which really. What's the point? I mean, I think, right, that was... Remember, there were some papers about nandrolone being used as a sole form of hormone replacement for...
The one case that's practical that I can mention where it would make sense, certainly, to use testosterone is that because it converts to dihydronandrolone, and DHT is essential for many men for erectile function.
Yeah, exactly.
You have enough testosterone on board. Typically a 1-to-1 ratio is good enough, but if you have a problem with that, you go to 2-to-1, and typically 100%, almost 100% problem solved, because your body still makes enough dihydrotestosterone to avoid erectile.
Progestational activity, and I say progestins also perhaps would be side effects of the cardiovascular system. Or assuming it absorbs the calcium, the DECA, and improves the bone mineral density, then in the long run maybe do some calcification in the endothelium.
Well, what about some of the water retention that one gets?
This is beneficial for the joints though, because it kicks aldosterone and everything.
But does it make the heart work harder, having more fluid build up?
This goes to individual stuff. Starting with the calcium, I mean, there's no doubt with anabolics or even testosterone, your body's going to absorb more calcium, so-called naturally that way. In other words, on TRT, such that even when I give Myers cocktails here, which tend, it's the kind of the cocktail of the day that has sort of everything to get started with, I pull the calcium out because typically you don't need it. I recommend not supplementing calcium for most people on TRT because your body hoards it. The key, if you want to make use of it, what I found is to make sure they get on D3. So you have the brick and mortar, but you also have the contractor to make it work.
D2 also.
Yes, so direct, yes, to the away from the vasculature. That's the current theory, right? But in terms of the aldosterone, who knows? And maybe who cares for someone who doesn't have CHF? What do I care about it? My blood pressure is maybe low. And the cool thing about nandrolone, again, going back to Lipschultz and Baylor University, where he works, and one of my colleagues, he works here, Todd, Dr. Todd, is they used, and it was an 8-week study, it's published, nandrolone for refractory joint pain. And it does work, but it doesn't necessarily work for a physiological reason of repair. Well, that makes sense to me because it's the first time I've heard that introduced as a possible additional reason, but we know that it works on pain. Yeah, we know that it definitely works on pain. The conversion of, I'm not going to remember it exactly, so I'm not going to say it on camera, but because I don't want to be misquoted, but there is a pain mechanism involved, which arguably is very, very helpful for another reason that, say it's malpositioned the shoulder. A lot of bodybuilders, they work on the pecs too much, and so they're protracted, right? And so you work on, because you can now get through a workout and do the work to do, say, teres minor work, you can pull your shoulders back. You can do some work to, pull it back by, using some rhomboid training, lower trap training, whatever it is. So indirectly, you're helping through the pain management, but it also makes sense to get some fluid in the joints. If you're raising the aldosterone, that's something I hadn't considered. That's smart. It makes sense.
Kick on EPO and hemoglobin when you implement also DECA along with testosterone. So you raise
it. Should raise, anything above a standard TRT dose, with or without sleep apnea, is going to raise your H&H a bit. Yeah.
I mean, what are your thoughts on the elevation? I mean, there are some talks in the area that erythrocytosis secondary to TRT is not the same as polycythemia vera, which is not. Polycythemia is absolutely not. Yet many of the traditional insurance-based doctors will conflate the two.
No, it's about the blood,
and they always mix it up. So, what are your thoughts on blood donation or managing hematocrit and hemoglobin? How important is it from your?
How often?
Well, what I have found in my practice, okay, is that with very few exceptions, the elevations in hemoglobin, hematocrit, and red blood cell count are secondary to sleep apnea that's left untreated. And when you introduce testosterone, especially for someone who has had less than optimal levels of testosterone, which is required for the manufacture of a red blood cell and the hemoglobin thereupon, all of a sudden you see this rise in hemoglobin and hematocrit, which has been countered by the fact that you didn't have the testosterone. So, of course, the primary care physician goes, see, I told you it's that damn testosterone that's causing this. Well, it's not. It's leveraging it, and it's the sleep apnea. And 100% of the time, except for a very, very rare gene mutation, a JAK2 gene mutation, it's because of the sleep apnea that when treated properly, because we had this discussion at lunch, CPAP doesn't always work. It's one of the worst solutions, unless you're 350 pounds, you have no other choice, but to shove air down your airway as a resolution. But if sleep apnea can be properly treated, successfully treated, the H&H goes back to quote unquote normal within normal limits. It's not the testosterone that's the problem. That's what I found across the board. Now, when it comes to blood viscosity, if you go into the physics of it, we talked about this a little bit last time. I would love to be a physicist if I could have, if I had the smarts for it, number one, and I could have made a living at it. But there is a correlation between viscosity and stickiness, but they are not the same thing. Yeah. Okay. Yeah. But most people treat it that way, including even some hematologists. So, oh my goodness, well, you're at risk of death because your hemoglobin is 19.5. Well, tell that to all the people that are in Aspen, Colorado, that come to see me there. I have an office there, and I see it all the time in the mail.
Those people adjust.
Of course they do. If not, they'd be not having a good time living at 8,800 feet all year round, right? So I call the you-know-what flag on that one, okay? For that just practical sort of, I'll call it an obvious, well, that doesn't make sense. But also, there is a difference between stickiness and viscosity. Now, if the blood is so viscous that it slows the progression through the vasculature, it makes sense. I use the example like you have two magnets. Well, if you go like this really fast, they're less likely to clump together. But if you go like this, then you have a chance for them to stick, right? That's as close as I can get without getting into the true physics of it, to say that, yes, there's a correlation, but not like the doctors assume. I've seen patients with true autoimmune polycythemia rubra vera that have H&H numbers that you go, that's not possible, that are walking around doing fine. I see them at Gold's Gym a lot, and they're doing
fine. The key factor is the platelets, the thrombocytes should be kept low.
Well, the key factor to me is, well, that obviously comes into play because that's more to do with the stickiness, right? But to me, it's, does the patient have any side effects? Because I don't see 21s and 23s in terms of hemoglobin often and commensurate hematocrits. What I see is typically somewhere between, say, 18.5 hemoglobin. I'm just using that because it's an easy number. Again, for the audience, you multiply times 3 roughly to get a hematocrit that's commensurate. But 18.5 to 19.5 is when symptoms occur. So that you get up out of a chair, and it takes an extra beat or two of your heart to get the blood from your legs to your head. And you go, whoa, I kind of feel dizzy. And it's not because you have a low blood sugar or you're dehydrated. Your blood is viscous, though, because you have too many of these red blood cells. Then I say it makes sense to go ahead and donate blood.
So really looking at...
Well, to keep it down, good question. As often as it takes to get it down to about, so you don't have symptoms, but typically the safe area, it's not the right word.
See, the lifespan of the red blood cells is 90 days. So
3 months.
Yeah, 3 months. Personally, I do it every 60 days. If I do it every 90 days, I go up to 20 hemoglobin.
Do you have side effects? Do you feel that dizziness? And erectile dysfunction can be an issue too, by the way.
It's heat intolerance.
Heat intolerance, it makes sense.
Sometimes it's blurry. Sometimes.
Yeah.
Occasionally.
Then that makes sense to tell the patient,
when
go ahead and do it.
My hemoglobin is 70.5. And this is a good number for me. Yeah. And I've been below 17, by the way, in my life.
Well, then again, you just answered the question. So you would go to what works for you so that practically speaking, and I do mean it comes down to practicality, you spend fewer times going to get, blood therapeutic phlebotomy, we call it. But here's the thing. And I owe this to a hematologist who knew what he was talking about. What are you doing? You're also tapping into your blood, your stem cells every time you do this. Do you really want to do that if you don't have symptoms and you realize that you're really not at risk? And even if you think you're at risk, well, take your fish oil, your curcumin, the things that they would give you to thin the blood, so to speak, or baby aspirin, not my favorite.
Yeah, something that we've used in Europe is pentoxifylline or pentoxifylline.
Yeah, you probably
I think is a brand.
And improves the blood flow, yeah.
just to cover your bases. But again,
the dose to smaller ones in order to avoid the spike in DHT, perhaps.
well, it goes back to the same thing we're talking about with using, an AI
Or the cream, which is important to pay
Paul, right?
or the cream.
How about fixing the source of the leverage of the H&H? Which is,
You can see it in the nose or the throat or the neck.
say again?
So for you, it's either in the nasal septum or the throat or the neck.
Well, somewhere in the airway,
Tubulars.
you're not getting, so, and you can prove it very easily. And I do it, I mean, at least once a day, I'm writing a requisition for an at-home sleep study so that I can see the oxygen levels in the blood, okay, drop to, and here's where it gets crazy too, and this is very confusing to the layperson, especially in this country, I should say. Just to anybody, what do you want your oxygen levels to be in your blood right now?
Yeah, 100%. Yeah.
Not
96, 97.
okay.
Is it low?
But it's probably an artifact of like, so I have this Oura ring that measures it, right? But it's measuring it on my finger, not in, it's not.
It's or even the one you put on your finger, like the pulse oximetry.
Right. So there's going to be some, whatever you want to call it, some imprecision there, some inaccuracy because it's on your finger rather than, in a main artery. But let's call it 97 then. We can live with that, okay? Or if you're at altitude, then you got to factor in, okay, I haven't acclimatized yet. It's going to take me 6 weeks. So it'll be 93, 94, and I have to accept that for a while. But let's just stick with sea level, 97%. They set the bar in this country at, a lot of the insurance-based doctors at 88%. That's absurd. I dare either one of you or any athletes out there, try and get on, I've done this, get on your bicycle or whatever you want and pedal as hard as you can to your, working toward your VO2 max, hold it, and see if you can drop your oxygen down to, a pulse ox of, I'd be surprised you get to a pulse ox of 93 before you said, I'm done. Okay. If that, okay, it's not going to happen. Okay. And yet when you're unconscious, you can get to, I've seen some 60s measured. Okay. That's going to create the training effect that most people are trying to get when they're on the bicycle or the treadmill, right? To get your body to respond. Unfortunately, for the smart people out there, they're going, well, then I don't have to do my cardio anymore because I'm doing it during my sleep. It doesn't work that way because it's one part of the whole process of getting in shape. Plus, it's happening during sleep when you're supposed to be regenerating, not training.
And then you wake.
So there's a lot of reasons. I'm joking, but I know a lot of people that go, oh, wait a minute. Then and smart people go, then I don't have to do any training, right? No, wrong. So you're using pulse oximetry very easily. I mean, you can buy some of these things on Amazon. Don't buy the $29.99 ones, but a $200 version will get you what you need for your sleep. And you say, oh my goodness. Oura works pretty well, by the way, to identify, oh, look, my pulse ox, the level of oxygen in my blood is dropping to a level that is making my body accommodate and create more oxygen carrying capacity. And that's the issue. 100% except for a very rare occasion where I see, oh yeah, it is a JAK2 gene mutation. Whoops. And there's not much you can do about that, but bloodlet, and that is actually a treatment. Or we can't make more red blood cells, but that's a whole other topic.
Yeah.
Very rare.
Very rare. So for most patients on TRT, there will be some increase. Sometimes it's a good thing because they've been at such a low base to begin with that it's good that testosterone does that.
I've seen doctors, I won't name names, of course, but doctors with anemia because their testosterone is so low.
Yeah, that's not healthy. That's not optimal. That's not right. I guess one of the things is as we get older, and I just want to see if you had any thoughts on two things. One is sarcopenia and loss of muscle mass, and I don't know if you followed the follistatin or the myostatin types of treatments. I know there's some clinic, I don't know if it's a legitimate clinic down in Prospero in Alto Honduras, and they're giving some what are they called, mini circle type of injections of plasmids of follistatin. Others have used follistatin. There's a pharmaceutical company, I think Eli Lilly, is repurposing a drug that they used for some sort of muscular dystrophy called bimagrumab. which is given by IV treatment. They're now going to repurpose it to go along with the Ozempics and the Mounjaros and these type of medications, because one of the things was those medications may cause you to lose muscle, but then so does weight loss. So they're going to combine the two, or have this two on offer. Have you any thoughts on in preserving?
Oh, I'm on studies for sure. I South Sea, you just gave me a broad window of response. So, yeah. Well, first of all, with the Ozempics and stuff, I mean, a lot has been made of the muscle loss that comes with it, which I found is not necessarily true. You know, if you do a modicum of exercise, you can prevent the disasters that people claim can happen, which I'm sure can happen.
Skipping meals, though.
Right, you're skipping meals, but you're also, you know, you're, and we've proven this with the intermittent fasting. As long as you're providing some drive for the body to at least maintain, or, you know, I'm probably not going to accrete any muscle mass, but, you know, you won't see as much loss as the doomsdayers say that are against this stuff. But it makes sense that a pharmaceutical company is going to go on to that and say, well, we've got the new latest and greatest combo that are going to help you. Okay, you can use a combo, or you can use testosterone properly, or an anabolic if appropriate, to the same idea.
Oh, geez.
Again, my perception, my thoughts on growth hormone are that despite what some people will claim, and there's a reason for it, if you'll let me hear me out for 1 second, but that it gives more muscle mass. Yes, you can get muscle accretion with GH, but particularly in the study that's always cited from the 90s with the older guys that were putting on, you know, what it was, 8.9%, all that kind of stuff. I think that what we're seeing there is technically a muscle increase, but it's because of water being put back into the cell where it belongs. We age and we drop from, you know, birth of 70% water to 50% water, so we're desiccating. We put water back into the muscle as it's supposed to be there, supposedly, right? You know, based upon what we believe of, you know, healthier you is when you were 20, and it's going to count as muscle tissue when you do any sort of testing. But you didn't create the muscle we're talking about, where we're loading up glycogen in the cell when you use an anabolic steroid. Can actually make, now we figure we can actually make some new sarcomeres and all that kind of stuff. So I don't think it's that same thing. I think if someone wants to put on muscle, I'd say, you know, do all the right things. And if you're going to use a drug, the anabolic's going to give you a much bigger effect, anabolic steroid, than HGH. But I think it is definitely useful, and particularly for ligaments and tendons. But where did we get off on? We were talking about something.
Sarcopenia, low muscle. We're talking about the myostatin inhibitors, and
yeah. So we used to be able to get follistatin here, no longer.
Okay.
But in the brief period where I was exposed to it through my patients saying, "Yeah, I got it from this place," or whatever, it seemed to work very, very well. And the studies show that's another avenue by which we might improve, counter sarcopenia with age.
it was noticeable difference, measurable difference.
Yeah.
Oh, yeah, interesting.
I mean, it's yet to be seen now, because
yeah, I mean, that's where I think is almost, I don't want to say conspiracy, but so odd. Like research in growth hormone, for instance, you can read the papers, and they're all from the 90s up to the early noughties, and then nothing, or other than a few meta-analyses. Yeah, and then same thing with these myostatin drugs. Many of them got to phase 3 trials, but they didn't mean that reach their functional endpoint. They increased lean mass, these myostatin inhibitors. They decreased body fat, but they didn't improve grip strength or walking out of a wheelchair, you know, if you had the Duchenne's muscular dystrophy. So they didn't get final phase 3 approval, or the company pulled it because they knew it wasn't going to go to phase. It's just really odd.
It's very frustrating, isn't it?
Yeah, because they are doing what they're supposed to do. They are increasing lean mass. There doesn't seem to be a lot of side effects. I think one of them has a particular nosebleed from those, but just like, where are we? And I think now, maybe in the next 3 to 5 years, we'll see a race to at least maybe having this come out, similar to how the popularity of the GLP-1 agonists are. We'll probably see it with myostatin inhibitors in some form.
I hope you're right. If the studies bear out what we think they might, as we talked about at lunch, you know, some of this comes down to study design is poor, and things get scuttled because we get results that are due to the fact that the study was poorly designed. It's right. It's as simple as that. I'm frustrated with ibutamoren, some know it as MK677, because it's being privatized now. The FDA has sent a letter, not making it illegal yet, but has suggested, and so the big pharmacy is like, heard that one, not going to make it anymore, because if you look in there's, I think it's LUM-201 is now the name for ibutamoren for the, I hate to say it, it sounds like conspiracy, but it is what it is. You have a big pharma that wants to make it available, you know, trademark it.
Right. Like they did with NMN in the US. They
have they? I have.
They had Sinclair may have had a patent on it, and he's converted something about creating the NMN formula, and then
Patented now?
yeah, well, he may have had something to do with that, and then they limited the NMN. I think it's come back on the market, but for a short period of time,
Oh,
I think in the US they were going after people who are selling NMN in the US.
I wasn't aware of that, but I think it's available now. But the frustration's there no matter what. When you find out that, you know, on the one hand, they're claiming, like the letter states, that we think these chemicals, or I'm paraphrasing, aren't proven safe, and yet you're about to give approval to the patent to a drug company. I mean, make up your mind, man. And it's a little frustrating for obvious reasons, but hopefully in one way or another, these things will come to market. Follistatin being one of, if the studies bear out that it does do what we hope it does, and we'll have it in our quiver to use for the patients properly. You know, that'd be great.
That'd be fantastic. I'll leave you on one. We talked about a lot of the benefits of TRT, HRT, and, you know, some of the detractors, you know, can be quite harsh. I've heard them say everything that, you know, this is part of the testosterone industrial complex, that testosterone is being kind of oversold and all the benefits. And I think that personally they're misplaced, because for so long, testosterone's been demonized as even a potential therapeutic. And the reason why you'll have things like on our channel and the things that you do and the things that George does is to get the word out that people can be helped. And these can be therapies that shouldn't be stigmatized. And so one of the areas I usually attack TRT is on the heart and heart health, as being, oh, you do testosterone, it's going to affect your heart. Now, you and I know it's not the case, but I just want to hear your thoughts. How do we fight those detractors when it comes to...
Well, that's the question of the day. Do we even bother? You know, do we bother to fight? You know, the hardest question to answer is a fool's question. And remember the parable about the lion, the donkey, and the king, and the donkey and the lion are arguing about the sky being blue or green or whatever. And the lion says it's blue, and then they go to the king, and the king says, okay, donkey, you're banished, you know, to prison for 6 months, and, you know, lion, you're banished for 5 years. And what? I was the one that was right. I said, yeah, but you gave quarter to the idiot over there. You wasted your time arguing with an idiot. Something like that. The story is, you know, do we waste our time? Because where does this come from? You know, just like, and not to pick on a profession at all, but there were some chiropractors that claimed that, you know, their adjustments, we'll call them, could cure everything under the sun. So it gave it a bad name. Stem cells, another. Stem cell doctors and clinics are claiming all kinds of stuff, giving it a bad name. There are TRT clinics that claim that TRT, you know, can do everything under the sun, giving it a bad name. And so, to enter politics in a bad example perhaps, but, you know, it's not the gun that kills people. It's the people that use guns to kill people. It's the TRT clinics, the bad doctors, I would argue, we'll call them, okay, not the TRT itself that's the issue here, and that people should be focusing on. Because anyone who tells you that, you know, testosterone is bad for you or whatever, I mean, you know, you're sorry, you're an idiot. Look, I mean, I mean, again, how do you answer a fool's question? The research is there, the results are there. I mean, you're Don Quixote out there or something. Now, when it comes to the heart, ditto. We find there's a correlation, not the same thing as causation, but a correlation between low T and coronary artery disease. You can come up with a lot of reasons for that, but the good cardiologist will attest to, even if it's just anecdotally, yes, it's actually good for you. The muscle, I mean, the heart is a muscle, duh. We go back to the abuse, which you've brought up many times, you know, whether it's of anabolic steroids or testosterone itself. And I've said it many times, the cliche, you know, the poisons in the dose. Yes, you can abuse anything. You can abuse aspirin, and you can cause a problem with your heart or anything else. So when done properly, those being the operative words, you know, optimizing testosterone typically optimizes the heart health. You've got someone, for example, that doesn't get his butt up off the couch. And I say him or her. And so just the fact that you have now the energy to get your butt up off the couch and do some exercise is going to be beneficial for the heart. No, making it very simple. Those simple arguments can be shot down very easily, I realize, but let's put the onus on the person saying that it's bad for the heart rather than the other way around. Let me be the smarter line. Let's not even go down that path, because what are you talking about? It's bad for you. Where do you come up with that?
Yeah, I mean, I think it's just conflating things with maybe anabolic steroids or abuse. We've had a cardiologist on the channel before, Dr. Sanjay Gupta, not the one from CNN.
No, I love Sanjay, the one in the UK.
But the Sanjay Gupta in the UK, you know, so yeah. So we had him, and he said, you know, testosterone is important for the heart. You know, if you do.
Right. So I know protection.
You know, even for heart failure, the doctor was saying, yes, testosterone is important for healing the heart and making it pump better and the vasodilation effects of it. So he was very much in favor. I didn't know your doctor.
No, I love him.
Yeah.
Now, I will say too, though, that again, to make my example perfectly clear, going on to what you just said, if you overdo testosterone, you don't do it properly. How about the people say it that way? You don't do testosterone replacement therapy or anabolic steroid therapy properly, and you develop hypertension. That alone, combined with too much muscle producing factors in the blood, you're going to get LVH, right? Left ventricular hypertrophy, which can lead to heart failure. So the opposite of what Sanjay say is good for you. But okay, but that's like a totally different subject because you're abusing testosterone anabolics, you're misusing, however you want to call it. And yes, that can create a problem. Just like you can take, do you have Tums in the UK?
Yeah. Oh,
Okay.
yeah. Something. Yeah. REMS. No, that's.
Do not use Tums like I'm about to mention, but I think with as simple as 1, maybe 2 packs full, if you ingest that, you can kill yourself.
Because of all the calcium.
Yeah.
Yeah.
Well,
Calcium carbonate. Oh.
Calcium, yeah.
Yeah.
The way it affects, when it gets absorbed in the blood, you can, you're throwing off your metabolic, what do you go into? Metabolic alkalosis, and you can kill yourself.
I think it's called REMS.
With Tums, over the counter.
Yeah,
I mean,
REMS, yeah.
we can go on and on, but you get my point.
Interesting. So yeah, so there's detractors, and there's always going to be in every facet of this. So I think that's. Any last words? Anything you want to talk about? And this?
No, just thanks for having me. It's
Thank you. Yes, so there's a prostate.
Oh, testosterone in the prostate. Yeah, I mean that's when it's come up. I know we've been watching some interviews from Dr. Morgenthaler. The latest is this the saturation model of testosterone. So for many years, and it still comes up. The detractors still come up and try to blame testosterone on prostate issues, etc.
Well, I always refer to his consensus from 2016, or published in 2016 in the Mayo Clinical Proceedings, where he got together with about another 20 experts in the field and came up with the 8 or 9 resolutions, one of which is to debunk that baloney. I used to have a bone to pick with him.
What about the pre-existing prostate cancer?
Well, that's another subject. But back in the day, he would say, I think it was 450 total T or less was the cutoff. And you're like, what do you mean? So what if it's 440, 449? And, what if it goes above and below and all this kind of stuff? And how can you draw a line in the sand? Now, he's come full circle and said, basically, same thing we all say now, which it comes down to the patient.
Right.
The number is not, you don't draw a line in the sand like that. That's crazy. So I love him now. I didn't hate him back then, but I did have an issue.
He was learning as well. And I think
exactly.
Part of that consensus was brought into the ISSAM group, the International Society of the Aging Males. And they also had a paper with clinical guidelines that talked about, I think it's about 450, 500, or 450 is 50 as when symptoms of low testosterone may occur. So I didn't see it as a direct cutoff because they also talk about the CAG repeats, how different men may be more receptive to higher levels of testosterone than others or lower levels based on the genetic.
Keyword being receptive, meaning receptors or not, how they react to it and all that kind of stuff, right?
Yeah.
Stuff we now realize. And I'm glad you said it the way you did because that's science. But to your point, there's a small study, there are probably more now, I haven't looked, where they use testosterone to treat extant prostate cancer. And we realize it's not the testosterone itself, it's the dihydrotestosterone that once you have extant prostate cancer fuels the fire big time. We believe now that the estrogen, and I said I'd throw you some of these examples when I dig them up for you, but the estrogen, the bad estrogens are what can activate the genes that we all carry for prostate cancer to develop. But once you have it, you definitely don't want to have the DHEA on board, right? So otherwise, testosterone, we believe, is protective of the product.
Yeah.
There is a correlation between low T and prostate cancer.
Yes, and prostatitis also.
Well, that makes sense too, right? Yeah.
And BPH. So now there's sometimes
it's not something bad. Everybody's going to get it at 80.
Yeah.
Well, and when I was in med school, in residency, I literally stopped the grand rounds as I was heading for my seat late, and I heard the speaker say that every male over the age of 80 has prostate cancer. I was like, everyone? Come on, this is medicine. Everyone, and apparently the studies is actually 82. Whereas apparently the studies showed that
Slowly growing cancer.
Yeah, and it might not be something that kills you because of a slow growth, or even symptomatic, exactly. But that's mind-boggling to me. But to your point, that eventually, the things grow, the thing itself grows, and whether you have symptoms or not determines whether you treat it or not.
I have a patient who's 60 years old from the States. He has prostate cancer grade 5. He has a PSA of 5. He's taking 100 milligrams of testosterone. He's taking 1 milligram of dutasteride daily. And he fools around with 30-year-old women, you know. He doesn't want to take off his prostate, and he enjoys his life.
I got one that might be even better than that. He's been a patient for a decade. Came to me with a Gleason 3+4. Decided same. He's 72 now. Did not want to treat it. Okay, figured he'd not roll the dice, but wait it out. It wasn't close to the margins or anything like that. Cut to the chase. I think it was about 6 months ago now. He's been on TRT with me. Is cancer free.
Really? Wow. Is he taking any 5-A reductase inhibitors?
Yes.
Okay.
Wow. Mm-hmm. It's more than interesting, man. It's so cool, isn't it?
So amazing that you can,
I mean, so it opens up the door. It's an N of 1, but you got to, and I'm, I had to say it, but I'm another N where, I didn't listen and I said, well, okay. But mine was stage 0, basically. No signs of it for 6 or 7 years now, and I didn't, I mean, I did my own thing. I haven't published it because I don't want to get a bunch of arrows in the back. I'll do it when I retire.
Okay.
But, well, I mean, I share with, and that sounds terrible what I'm saying now. Maybe cut this out, but
okay.
I want to share with anybody, but I don't want to share it too publicly because we know how that works.
Well, the stereognosis, I hesitate to take testosterone even after prostatectomy. Unless it's 0.
That's retarded, right? I mean, well, if it's metastasized, even then, because we know that it's the DHT that causes the problem, testosterone I would still use because even if it's, gone to lumbar or something like that, well, testosterone is not the problem, right? It's the DHT, at least.
Is it though? Is it all the DHT? I mean, DHT still binds to the androgen receptor. I mean, it's a bit more potently binding to the androgen receptor.
I don't know because I'm not an oncologist, but I think the issue is, it's way more potent. Depending upon the receptor, it's 2 to 5 times more potent, right? DHT. But that still,
what about the saturation model then? It does it to a certain point, and that's it.
But that might be the key to the difference between it being more potent. You say, well, okay, but then if I use a lot of testosterone, it would be just as much as that. If I use twofold as much testosterone, then it's just as potent as the DHT. But the saturation model might be the reason why that's not the issue.
Yeah,
or have something to do with it.
Or maybe there's another factor that we don't know about.
And we're still observing. And again, going back to, apologetically, if I even implied that I had anything against Morgenthaler, I don't. I love the guy and for what he's done for the medicine. But science is always changing based upon, the latest information. Doesn't mean science is wrong. It just means science is right depending upon the information we have at the time. Yeah. And so far, it looks like the DHT will drive cancer, so we want to keep that low, but the testosterone is protective when they're talking about prostate cancer.
Yeah. I guess we'll have to wait and see, watch this space. So,
well, hopefully we're all around.
Yeah, all around to see it. No, thank you so much for taking the time to do this with us.
Thank you.
Yeah.
Both you guys, man.
It's been a fantastic conversation. For everyone watching, please leave your comments, as you've done in previous videos that we had with Dr. Rand. And until next time, stay healthy and keep watching. Thank you.